And with that, we are going to kick off panel 3 out of 4, and I'm going to hand it over to CHLPI's very own Rachel Landauer.
Hi, everyone. Welcome back, and welcome to our next panel. As Carmel said, my name is Rachel Landauer, and I am also a clinical instructor here at CHLPI. And in this role, I am especially passionate about building the capacity of organizations through resource development, trainings, and conversations like this one we're about to have to really break down silos between healthcare and other sectors. And why, right? We've heard quite a few times already today that undertakings to serve the complex needs of our communities really require complex, multifaceted solutions. And more often than not, this means that we can achieve more better by doing it together. And so we need effective cross-sector collaboration in which 2 or more organizations or systems or entities really come together to collectively focus our expertise, our resources, and help us break out of our comfort zones and do new things. The reentry medication demonstration waivers are really no exception to this paradigm, right? We've heard a few times already today that these are really fractured systems in which people fall through the cracks in their care. And the role of the waivers, it's really about smoothing transitions. It's about addressing social determinants of health. And so in order to do this, we really need that coordination, that communication, and the relationship building across systems, across organizations, and those are really critical investments to be setting up as we go in. At the same time, we know that meaningful cross-sector collaboration doesn't always come that easily or that naturally for our organizations. And so today, I'm joined for some perspectives on how to by 4 panelists with, I think, pretty tremendous expertise and insight into breaking down silos and building bridges to achieve more innovative and impactful change. And so we have, well, you're sitting in a different order than my notes. All right, we have Emily Wang. Emily is a professor in the Yale School of Medicine and directs the SEICHE Center for Health and Justice, a collaboration between the Yale School of Medicine and Yale Law School. The center is committed to ending mass incarceration by working across the disparate domains of health, law, and criminal justice through direct clinical care, conducting research, educating health students and professionals, and driving legal advocacy and scholarship. Dr. Wang leads the center's research program, which receives National Institutes of Health funding to investigate how incarceration influences chronic health conditions, including cardiovascular disease, cancer, and opioid use disorder, and uses a participatory approach to study structural interventions which mitigate the impacts of incarceration. Her work has been published in The Lancet, JAMA, American Journal of Public Health and Health Affairs, and showcased in national outlets such as the New York Times, NPR, and CNN. As an internist, she's cared for thousands of individuals with a history of incarceration and is co-founder of the Transitions Clinic Network, a consortium of 48 community health centers nationwide dedicated to caring for individuals recently released from correctional facilities by employing community health workers with histories of incarceration. Dr. Wang serves on the board of the Committee on Law and Justice of the National Academies of Science, Engineering, and Medicine, and the World Health Organization in Prisons program. She was inducted into the American Society of Clinical Investigation in 2021, the National Academies of Medicine in 2023, and was awarded a MacArthur Fellowship in 2022. We also have Denise Sanderson, Clinical Services Integration Coordinator at the Bureau of Infectious Disease and Laboratory Sciences here in Massachusetts Department of Public Health. Denise has been with the MA Department of Public Health since 2015, coordinating projects related to the integration of HIV, hepatitis C, sexually transmitted infections, TB, and substance use and harm reduction services in agencies funded by the Bureau. She's worked closely with Houses of Correction and the Department of Correction since 2020. Prior to the Department of Public Health, Denise spent 10 years at the Lowell Community Health Center as the HIV Adherence Coordinator. Next to Denise, we have Kim Prendergast, Vice President for Policy, a Community Care Cooperative, which is a community, well, it's here in the, I'll get to it. For Community Care Cooperative, C3, a federally qualified health center-led, accountable care organization based in Massachusetts. In this role, she leads the ACO's strategic and policy initiatives to support FQHCs, federally qualified health centers, to leverage value-based payments and address social drivers of health to improve health equity and health outcomes. Kim joined the organization in 2019 and was the architect of C3's work to build partnerships across the healthcare and social services sectors, designing and implementing their $20 million flexible services program through partnerships and contracts. Today, C3 partners with more than 25 community organizations and has supported nearly 15,000 C3 members with interventions to improve food insecurity, housing instability, and homelessness. Prior to joining C3, Kim spent 2 decades addressing food insecurity and health with Feeding America through roles in public policy, nutrition programs, and healthcare partnership consulting. Kim is a registered dietitian nutritionist with a BS in dietetics from Purdue University and has a Master of Public Policy from the University of Chicago. And then last but not least, we have Christian Ramers, an adjunct professor at San Diego State University. Dr. Christian Ramers serves as the Assistant Medical Director for Research and Special Populations at Family Health Centers of San Diego. He earned his medical degree from the University of California, San Diego in 2003 and completed his internship and residency at Duke University Medical Center in internal medicine and pediatrics. He completed a fellowship in adult infectious diseases and received a graduate degree in public health at the University of Washington. Dr. Ramers leads several clinical and educational programs supporting HIV and hepatitis C treatment within our clinics, consults for the California Office of AIDS, the CDC, and Project ECHO on HIV and HCV, hepatitis C, related clinical care initiatives. And he is a co-investigator on several NIH-sponsored research projects in collaboration with the University of California. Dr. Ramers maintains a busy bilingual clinical practice providing specialty and primary care to underserved and homeless individuals of all ages. So thank you all so much for joining us today. I think I really want to start us off by maybe hearing from each of you about a core cross-sector collaboration that you're part of to advance health equity among justice system involved folks specifically or other vulnerable communities, right? So who's part of the collaborative? What is the goal? How is it going? And Emily, I'll start with you.
Thanks so much. I really appreciate the opportunity to be here. It's a real delight. And I'm standing in for Dr. Shira Shavit. She's the executive director of our Transitions Clinic Network, so I'm really putting that hat on today. And Manya Saunders couldn't have done it any better of really describing the core crux of what our Transitions Clinic Network is. She's the community health worker that was talking about her own lived experience as she applies that expertise. But this is a model that's based on 15 years of experience where we brought together people with histories of incarceration, their family member, healthcare policymakers, Medicaid in particular, Department of Corrections leaders, and this was in San Francisco and California at the time, community health center leaders, physicians, about what were the sorts of interventions that we needed to improve the health outcomes of people that return in and out of jails and prisons. And, led by people with histories of incarceration, and I can't tell you how important that was that they were there at the beginning, guiding the early conversations. It is they that decided that they wanted community health workers with a history of incarceration. They wanted people that had had that experience themselves, that knew what it felt like to go through the health system where they never really trusted the healthcare system to start, but actually were first accessing healthcare interventions and then would come home to the community health system where they felt uncomfortable talking to their physicians about it. At the time, there wasn't expansion of Medicaid. There was often no insurance, no ID, no ways of going to get employment, housing, food. And so they identified community health workers. And so it's in this setting, cross-sector, but led first and foremost by the values, perspectives, and needs of people with histories of incarceration, that we created this model first in San Francisco, have studied it, scaled it, and learned from ups and downs. And it's now in 14 states and in Puerto Rico where we have 48 programs. And Manya, it works closely with now hundreds of community health workers. We've taken care of thousands of people that have come home and are excited to share our experiences in a cross-sector kind of collaboration, but again, grounded fundamentally in the experiences of people with history of incarceration.
Thanks so much, Emily. Denise?
Thank you. So the Bureau of Infectious Disease and Laboratory Sciences has a long history of working with the corrections facilities and justice-involved individuals. So the work sort of started back in the 1990s. Originally, we funded an infectious disease nurse and an infectious disease coordinator, and then 4 infectious disease nurses to provide integration in the Department of Corrections. So that was 19 facilities across the state. In the early 2000, we added HIV coordinators to do some of this work. And the way it worked was DPH paid half of the salary and the Sheriff's Department paid the other half of the salary. These individuals did education, they did some testing, and they did really, really minimal transitional planning. It wasn't really the focus at the time. And this system was in place till about 2012 when the funding shifted. And in its place, we started something we called Corrections to Community. And it was for persons living with HIV who are leaving the facility. So it had some aspect of pre-release case management services and then linking folks to case management upon release. And right around 2015, we started to see a decrease of individuals being diagnosed with HIV in the correctional facilities. And we also saw that most of the individuals who knew their status upon being incarcerated, they were already linked to medical care and case management services prior to entering, and those were likely the places they were going back to upon release. So they didn't really want or need the service. So in its place, we did an assessment around 2015. And across the board, the Houses of Corrections identified the need for release planning for not only HIV folks, with folks living with HIV, but also individuals who are hepatitis C positive and individuals living with substance use disorder. This was by and large the biggest identification. And we talked about it before, and it's been talked about, reentry is such a high-risk time, so we knew that we needed to work on getting folks linked to care soon upon release. In its place, we have something we call correctional linkage to care, and it has a pre-release and a post-release component as well. So there's 6 months of working with an individual while they're incarcerated, and there's some time after they're incarcerated as well to help them get linked and stay retained in care. And the purpose is to successfully link individuals who are either HIV positive or hepatitis C positive, link them to medical care and other essential health supports in the community. And the focus, again, is on individuals with substance use disorder, again, knowing that these folks have a particularly hard time upon transitioning back into the community. And so in terms of how it's going now, it's going really well. We continue to fund an infectious disease coordinator at the Department of Corrections that we work with, and we also have an infectious disease coordinator at the Suffolk County House of Correction as well. And we had the Correctional Linkage to Care program in more than half the facilities across the state. So these are folks that are working, again, with individuals while they're incarcerated and linking them to healthcare and supports in the community. And then we also have a dedicated staff person in the Bureau of Infectious Disease who can continue this work and move it forward.
Thank you so much for the opportunity to be here. So I'm Kim. I'm the, as Rachel mentioned, I work for an accountable care organization led by federally qualified health centers. So we're in 7 states, but working in Massachusetts with 23 federally qualified health centers. And so that's the perspective I'll bring today. And there's 2 points that I wanted to make. One, Rachel mentioned the flexible services program. And so in Massachusetts, Medicaid has given us, through the Section 1115 waiver, the ability to work with community-based organizations to provide direct goods and services for Medicaid members who meet specific health criteria who need food security and housing supports. So those programs are managed by the accountable care organizations, and we've developed partnerships with about 25 organizations across the state to really be able to leverage support when our community health workers, our providers in the health centers are screening members for food insecurity, housing instability, identifying those needs. We're able to directly refer those individuals into these programs with very intentional, robust workflows that make it such that a member is referred and someone's calling them, and we're building more capacity in the community and allowing those programs to pay for the kinds of needs that members have. We have lots of individuals experiencing homelessness or at risk of housing instability who are returning citizens and really stuck in that position of not able to work yet, kind of falling through the cracks. And so we find lots of individuals that are referred into flexible services that we've been able to support in that way. The other really exciting program that's happening in Massachusetts, while we continue to wait for our waiver that allows us to expand what's happening with Medicaid, we started this community support program, and this is a covered benefit for Medicaid members. Started focused on behavioral health, sort of broadly, and then they've created some specific community support or CSP programs, and one is for the justice-involved population. And so providing very intentional case management supports for individuals who are returning citizens, working with peer recovery coaches, with community health workers, with lived experience. So I checked this morning, and we have 233 individuals enrolled in that program today with 9 organizations around the state. And it's been such a great way for our health centers to work with community organizations that have that expertise. They're able to refer into the program. The community support providers can work with the health centers to assure that they're connecting members back to healthcare as that's needed. So we can talk more about those partnerships, but it's been a great operation for us.
Thank you. So I think I was invited here to give you the unvarnished community perspective. And I just want to thank Carmel and Liz and Jonathan for inviting me here. The straightforward answer to your question is that we now have a Healthy San Diego CalAIM Justice Involved Work Group, which meets monthly. It brings all the people that need to be there to the table, and we're starting to talk about this incredibly complex rollout of what this is hopefully going to be in California. The real unvarnished truth is I've missed that meeting, the first 3, because I'm too busy doing other things, actually. So I made the last one. It's great to see all this happening. But another example is a cross-sector collaboration that is more of an immediate crisis, to be frank with you, which is our homelessness crisis in San Diego, obviously overlapping with justice-involved populations. But we have 8,000 people in downtown San Diego that are homeless. And the city is now doing things to displace them from the sidewalks into encampments, and we're now scrambling to take care of those people with all the service providers not really knowing what to do, the managed care organizations not knowing how to deal with it. And that just organically has come up as a cross-sector collaboration group that we've had to sort of deal with the crisis in front of us. So that is running in parallel with the Justice Involved Work Group, and it's a lot of people that have previously been competitors or not the most friendly partners. I don't love managed care organizations because they limit the care I can provide to my patients, and yet I'm being asked to be in these work groups with them. So lots of work to do, and I'll have a lot more to say about the complexity of everything going forward.
I love that, and I think that speaks all of these answers, right? We're seeing strange bedfellows. We're seeing that requirement to come out of our comfort zone. We're seeing the requirement to leverage our own expertise and be able to leverage the expertise of others that we're working with and our limits, right? So I think Vicki, when she started us off today, she talked about there not being a roadmap, right? And that there's no one way to do this work that is just readily modeled for you. But we can think about how do we build up our toolkit, right? And when we think about cross-sector collaboration, What kinds of strategies can we look to and think about building into our own program? And we've started to hear a lot of different things that reflect needs talked about in earlier panels, right? I heard a little bit about assessments of who's doing what in your community. I heard about workflows, right? Which help to have some of that accountability and to shore up our systems so that we really do know how to follow the person through their different points of care. But I want to ask each of you to maybe share with us something that, in your experience, has been really pivotal or necessary in supporting your cross-sector collaboration. And if you have kind of like a favorite tool, right? Opening up that toolkit, what's one thing that you draw upon and that you want to share out? So maybe, Christian, this time I'll start with you and we can come back down this way.
Well, I think what is extremely pivotal are the relationships amongst the people. And actually, having just lived through COVID for 3 years, which is, I mean, I still can't sleep because of the 28 people that were my patients who died of COVID, and I also dropped everything else that I was doing for 3 years to sort of deal with that. But what COVID did is it brought us together to solve this incredibly existential problem. So now I actually know, I'm familiar with people at the county that I need to work with and people that are on the homeless task force. And actually I am familiar with people in the managed care organizations because we all had to be brought together in this incredibly bonding and traumatic experience together. So the relationships themselves are actually the most critical part. I think it was Tyrant who mentioned this analogy of like this car, and you can't really have a car that doesn't have an accelerator, or it doesn't matter how good your key works. The whole thing has to work together. And what I've seen just in the preliminary work in the justice-involved population is that we're only as strong as the weakest link, actually. So if we have everything in place and we have great case managers and social workers, it doesn't do any good if our county is too bureaucratic to make things actually happen. So we all need to work together, and we all need to lift each other up to make this happen. And then one other comment, not to be a downer about the whole thing, but somebody told me, I asked around my own organization from the case managers that are starting to work on this. And I spoke to the person working on housing. Okay, we have this, again, I mentioned this problem of homelessness in San Diego. The average cost of a studio apartment in San Diego is $2,000 a month. So you could have you could have an army of housing navigators. That doesn't do any good to this external threat that is the problem that's around us. So, but the positive point I was making was relationships and knowing who you can reach out to and text and just get that answer that you need to in the nick of time.
And I want to harken back to our first panel, which talked about how the reentry waivers don't have to do it all. And it's not realistic to ask the reentry waivers to do it all. But that there are, for example, these other policy levers that are really promoting investments in housing, in our food systems, and that we can be working together when we have kind of those directed goals, and then prioritizing justice-involved populations as one of those populations that are going through a transition that would most benefit.
I have a couple of tools that I think are important. The first is money. And from, as a Medicaid accountable care organization, I think we see opportunities where funds can support through the community support program that I mentioned. We see a lot of our health centers that are also getting grants to do this work, and to build upon your point about the partnerships, the relationships are so important. And sometimes it's an organization that received the funding that makes the most sense. Sometimes, so you have to build upon what the relationship is. We have some health centers where they were able to fund a community health worker who had lived experience, who had some relationships, was able to build up a program such that they were able to, build trust with individuals before they came out of incarceration and support that reentry phase. Whereas other times it's an organization in the community who's waiting there the minute someone comes out and is able to start building that relationship at that point. One of the things that's been really valuable for us is to see organizations, so we have health centers and then we have community-based organizations that might receive funds for various programs funded by Medicaid. And that's been really valuable to work with organizations, understand how it fits together and how some of the Medicaid design has worked. One of our partners that is both a community support provider and works with flexible services is able to talk about, they can do an assessment and really think about what program will best meet the needs of this individual. We want to assign a case manager who has lived experience with reentry, and we want to get them enrolled in the housing organization so that my flexible services program can pay their first and last month's rent and really help them think about what kind of housing solution will be right today while we figure out, workforce and employment and other benefits. And so having those organizations that understand all of it to be able to pull it together. And then it's just really having some great staff that can empathize, that can be successful in building those trusting relationships, just to provide this kind of support that people need.
I think, obviously successful cross-sector collaboration requires a lot of key elements, but I think the two that sort of stand out for me, obviously one is communication. Open, transparent, and regular communication. And I really want to sort of emphasize the regular. People are busy. There's so much, Dr. Amer just said, you miss meeting. There's so much going on. People can't be in two places at once. But the best that we can do, set something and sort of have a date and sort of stick to it. You have a date, even if you can touch base briefly. I've had sort of calls that have gone, an hour and a half, and I've had calls that have gone, 3 minutes. Just so they know every Tuesday, the third Tuesday of every month at 1 o'clock, I talk to this person kind of thing. And that's really worked well. I have monthly check-ins with the infectious disease coordinators, both at the DOC and at the Suffolk County House of Correction as well. And we do staffing updates, we do programmatic updates, we do sort of challenges, sort of next steps kind of thing, but just that sort of monthly check-in has been really, really crucial for the work. Also, sort of along the lines of communication, we convened a meeting in December. It was called Infectious Disease in Carceral Settings. We invited sort of stakeholders from the corrections across the state back in December. We had just over 100 folks come. So these were correctional health staff, there were ID coordinators, there were health service administrators. We kind of just sort of talked about things. I'm also lucky enough to attend monthly meetings or quarterly meetings with the health service administrators that are convened 4 times a year, sort of just to provide updates on the work that we're doing and also for DPH to hear the updates that they're doing. And we also have, these are recent, we also have regular meetings with the Mass Sheriff's Association and Carrie Hill, so we have a great advocate and that team as well, so it's been really, really helpful. And the one thing I just wanted to mention was just sort of flexibility and adaptability. I can't really say enough about that. Despite the best laid plans, we all know how things change. And I think we sort of need to look at that change as an opportunity to sort of rethink and reassess and kind of see how things are going. Funding changes, especially in state government, grant funding, it's never the same. Leadership, there's staffing changes. And while it's not generally an issue in Massachusetts, the political environment can also be a factor in the work, and I know that that's going to be an issue, I think, for a number of states.
So I will probably sound like a broken record, but I'll just start here by saying, when I think about kind of the tools that are important, the kind of human resources that are most important, it's really kind of the training, the salary, the support for community health workers. And, I just wanted to peel back even a wider lens, which is to say, Vicki painted an important kind of a mind-blowing opportunity for those of us that have been in this field for the last 2 decades. I think it's probably one of the largest criminal justice reform policies that are coming through that are going to kind of transform the health of individuals that have been impacted by incarceration, these 1115 waivers, if done right. And when we look at the Affordable Care Act, which again has really expanded Medicaid for justice-involved populations, and national studies have shown this, we've seen increase in uptake in Medicaid, no doubt, using national population-based surveys, National Survey of Drug Use and Health, but we have not seen improvements in behavioral service engagement, following release, nor in substance use treatment. So it's Medicaid is necessary, but it's not sufficient. And our work at Transitions has shown that a key piece of this are people, community health workers with lived experience, people with criminal records working within the health system. So what does that mean? Really what tools need to exist for that to happen? Well, it means being able to talk with your HR about what the hiring policies are within our health systems. If Vicki is saying that 17% of our GDP right now is in healthcare, it's a huge, important employment opportunity for our communities. 80 million individuals in this country have a criminal record. And so if the hiring policies aren't aligned in our health systems and our federally qualified health systems, if the CHW certifications do not have permission for people with criminal records to become community health workers, then we need better tools, better ways, better systems for integrating this expertise into these 1115 waivers for the promise to fully be achieved. Our data from transition shows that once you get community health workers involved, in fact, engagement goes from 30%, of post-release follow-up to 70%. It's not a surprise. When community health workers get involved, as Manya indicated, the return to jails and prisons actually goes down, and we've shown this using administrative claims data in Connecticut. And so the tools then that need to happen are ones where we start kind of training physicians to work alongside community health workers. This isn't training that I got as a doctor. How do you best utilize community health workers, create these multidisciplinary teams where they're really kind of able to work within health systems to the best of their scope of work to really extend the work we're doing. And so I think that there's lots of excitement, great, Medicaid's going inside, and I think it's huge and important. But then now, catalyzing the change that we need to see happen involves tools that really support community health workers. And it's tied to transparent communication, including community health workers on team meetings. They're not just like some side person that's out in the community, but they're in the room, in primary care, making decisions about programming. It also includes funding. How do we fund community health workers? So it's amazing in certain states like Massachusetts, but it's not amazing in Connecticut, where we're fee-for-service and don't have a way of payment. And so to me, and then the relationships, there's no one that makes a stronger relationship in a community than a community health worker. Manya knows every single reentry worker, housing person, Medicaid benefits person, the DMV, who's running the halfway house. Without that, she knows all the folks inside the Department of Corrections, goes inside and knows the families to which they return. And so without that critical piece and the tools that support a community health worker, this won't work.
And I think one thing I'm hearing from all of you is really this idea of, even for cross-sector collaboration, we require some kinds of both big P policy enabling factors. So some of the rules and regulations around us have to really support and facilitate that engagement, whether it's, for example, CHW or community health worker reimbursement, and also little P policy. So it's easy to think about the partners that we want to work with, but we might also have to look internally at our organizational policies and procedures and think about, how do we have to show up at the table? What changes do we have to make to really be our best partner and be leading with our assets in this kind of partnership? So I want to switch gears just a little bit and ask about, who even are we talking about having collaboration with? Because I think, houses of corrections, departments of corrections, and healthcare are kind of obvious partners, but there's a whole world around us. We've talked a lot about kind of the whole person care, the whole community care. Who else are we thinking about bringing into the table and how? And so I'll shake the order up a little bit this time. Go to you first, Denise. I'm wondering kind of what role you see for departments of public health or public health organizations in collaboration on these waivers.
I think we just talked, the Department of Public Health can work with the correctional health partners, and with Medicaid. I think one of the things we could do would be to develop care guidance for incarcerated individuals. And this would include sort of what a health assessment would look like, what infectious disease testing might look like, including HIV testing, hepatitis C, STI testing, disease staging, treatment initiation and completion during these 90 days, during the 90 days coverage. And I think, obviously the goal is to sort of, ideally, to initiate a lot of these services during incarceration and sort of optimize the health outcomes when folks are released back into society. I think also similar to sort of what they do, like when someone is released from the hospital, establish like a referral to care plan. When folks come out, there should be some standards around what that looks like. Schedule telehealth visits, ideally. We talked about InReach earlier this morning, having communities-based organizations, health centers come in to the facilities and do telehealth visits, prior to connect with patients and make those connections, again, prior to release. I think DPH the Department of Public Health can also work with, folks that are HIV positive to sort of connect them to the HIV drug assistance program. The same with folks who are utilizing PrEP, the PrEP assistance program, making sure folks are connected there as well. We also talked about sort of making sure individuals are provided with medication upon release. Obviously this would be billed to Medicaid upon release, so they have this sort of on their person when they leave facilities, and that's whether they leave in the courts or whether they ever leave from the facility itself. And individuals with substance use disorder, just again establishing the connections to community-based treatment providers and programs, and ideally again scheduling some of these visits prior to release so that the connections are there when folks come out.
I think that's such a good point because I've seen departments of public health across the country are such important resources for a lot of those community organizations and have such great partnerships already with a lot of community organizations in those spaces that they provide so much technical assistance to, that they convene. And so I love how we can think about leveraging that and the network that comes with that. Kim and then Christian, what about sort of MCOs or ACOs? What about healthcare providers, right? What is their role? How do we envision them coming together in these waivers?
Yeah, absolutely. So, most Medicaid across the country is run through managed care. My organization is one level down as an accountable care organization, which really bridges between the health plan and the providers. And so we talk a lot at Community Care Cooperative. We are governed by health centers and are much, much closer to the provider work than a managed care organization. But I think for my kind of organization, as well as a managed care organization, we're the ones having the opportunity to think about how to implement the results of the waiver, and then it's Christian and others who are really on the ground. And at the end of the day, these are local programs. And so my hope is that we're making it better for our health centers, making it better for our community partner organizations, as opposed to making it more complicated. So making sure that we're funding the right kinds of staff, we're really encouraging salaries that make this work. We're taking, in the work that I do, we're trying to take a lot of the administrative burden off of our health centers such that our community health workers, when we built our flexible services program, we sat down with community health workers and said, this is what it will look like to make a referral into these programs. This is going to be this many clicks on the computer. Is that something that's possible, or did we just make this too difficult? And they said, as long as we're getting this at the end of it, then we can work through that process. But really thinking about what does it take, and I think, as provider organizations, advocating back to managed care, to your accountable care organizations, whoever's paying those bills, this is what we need in terms of the staff and the workflows that make it possible and creating those partnerships. But really at the end of the day, we recognize it's the staff at the health centers, it's the staff and the organizations. And so how is it that we're able to bring together the right kinds of supports? One of the other notes I made to myself is thinking about medical legal partnerships. And so we're bringing in partners to be able to, even if we are not able to provide supports to individuals, to provide some guidance and advocacy to the community health workers such that they are able to steer members in the right place. We know that in housing courts, the majority, something like 95% of individuals in housing court don't have they don't have a legal advocate with them. So if we're able to help the community health workers understand what to tell folks when they're facing eviction, that's going to be helpful. So really just thinking about all the ways in which we can support our local collaborations.
So I'll comment first on just public health, and I'll talk about the FQHC perspective. We work very frequently with our public health partners, but I feel sorry for them because their budgets have been so hollowed out over 20 years that the only role they really can effectively fulfill, the only several roles is data. I mean, they are the data integration place for a lot of reportable diseases and things like that. And then as a convening partner, and that's really what they're doing these days with this initiative and with many others, because they have all those relationships that are so important. In terms of who FQHCs are, for those of you that don't know, federally qualified health centers take care of about 30 million people in the United States who are disproportionately of color and 90% low income. And we are the safety net. Just think of what a safety net actually is. Everybody that falls through the cracks of every other system ends up on our doorstep. And we have to take care of them whether they have insurance or not. We can do a whole lot with a person who comes to us through the door, first of all, makes that appointment, which is a big feat in and of itself, but also has Medicaid. This is a very important initiative, the Justice Involved Initiative, and I know everybody here is extremely passionate about it, but the way in my world this works is this is one chapter of a very complicated story of Medicaid reform in California. You've heard this word CalAIM, Medicaid transformation. That involves Justice Involved Initiative as part of it, but then there's also enhanced care management, and there's community supports, and there's behavioral health, and there's dental health. This is this crazy, massive thing, which I do international work with the Clinton Foundation. We're just chipping away to getting to a universal healthcare system, which just makes a lot of sense. But we're doing it in this totally maddening, complicated, iterative way in the United States because that's the way we do it. But when you get to the end user, that community clinic, if someone can make it in through the doors and have the courage to do so and not be so traumatized by their prior experiences with medical care in the past, and have Medi-Cal in place, we can do a whole lot with that. We can now provide them food and housing and case management and all this wonderful stuff that we've been doing within the HIV care system with Ryan White, CARE Act funding, all that kind of stuff. I have my fingers crossed that this is all going to work really well, so that I, as a clinician, can see a patient and be able to do a whole lot with them. I'll just give you one quick example from this week. We run a very robust hepatitis C treatment program, and somehow somebody showed up on my schedule who came in, and he showed up as a non-contracted payer, which, we have to see people because we're a community health center, but it's very limited what I can do for him. My hands are basically tied. So I go through the whole visit, I work him up, and I talk to my medical assistant, what's going on with this? And they look him up in the Medi-Cal system, and it says he has an inmate exclusion. And that is the most heartbreaking and humiliating and angering thing. I didn't go to medical school and do 15 years of training to just have my hands tied and not be able to do anything for this person. If the whole system works, in 2 years, he will have been seen 90 days before he was released, get signed up for his Medi-Cal, and show up to that very same visit, and then I could treat him that same day. That's what I'm hopeful for, and that's what we as providers are really ready for on the other end.
Thank you. And then, Emily, I'm going to alter the question a little bit for you because I think, you've already made it really, really clear to us and really importantly communicated that people with lived experience and community health workers and navigators have to be part of these collaborations. And so I think for you, my question is, how do we really what is the ask of Medicaid, right? Medicaid as sort of a leader of the waivers. What is our ask of Medicaid in terms of how to support cross-sector collaboration and how to help be a facilitator in that way?
Yeah, first off, I just want to echo, our transitions clinic programs are in FQHCs, and it is just, it's really and truly, it is the place that's kind of taking on this patient population, but it's painstaking work as a physician and as a community health worker, and so it's one of these things where the resource, the financing, I think, is critical. So maybe I'll give as a patient example, 2 examples of a patient that we saw last week in clinic, Manya and I, that came home. We live in Connecticut, and since 2014, Connecticut has made real efforts, the Department of Corrections, to get everyone on Medicaid prior to release. So about 95% of our patients are already coming home with Medicaid. But this person comes home and, again, was incarcerated for 10 plus years and does not have a state ID. And I just want to, people this morning mentioned it, and I just want to come back to what that means. You have Medicaid turned on, but you don't have a state ID. And we just worked, Transitions Clinic Mine in particular, worked to get an ID as part of the discharge process, and it feels so basic. But it's a cross-sector collaboration between the DMV, the DOC, and DSS that manages Medicaid. And DMV has never been part of the conversation. And so what that means for the tens of thousands of people that come home is that, okay, fine, they have Medicaid, but they can't go get glasses at an optometrist because you don't have an ID. You can't actually get checked into the health system. You can't get food stamps. You can't get housing. You don't have an ID. And so one example, just to give you all, is just to think through, is Medicaid can be a convener of unlikely suspects within the state to really bring forward the real needs of our patients led by community health workers like Manya. You wouldn't know that you need DMV at the table, but you need it. And in fact, without it, you can't realize the promise of Medicaid. The second I would say is that all of these 1115 waivers have embedded with them an evaluation plan. And in order to appropriately evaluate Medicaid at the very basic level, you need a linkage between the Department of Corrections and Medicaid administrative data. There's only 2 states right now that prospectively link it. It's Massachusetts, of course, it's amazing, and Maryland. And it requires huge amounts of legal, bureaucratic, strategies to make sure that it's not just these 2 systems, but you can imagine that the spillover effects that Vicki talked about, it has on labor, housing, child welfare, DCF. All of this could be appropriately evaluated if only our states invest in the infrastructure. And so I just wanted to bring that too, which is that it's not just, again, in clinic, same patient, thinking about electronic health records. As a doctor, that guy that you saw in clinic that has, we get like this little piddly piece of paper that maybe has his medications or her medications, their medications, but nothing about kind of their diagnosis of cancer. This morning, Stacy mentioned that patient with cancer. Nothing about the chemotherapy regimen, nothing about the 10 years behind bars where they got preventive care. And so we need the data systems linked, but we need it linked with the high eye towards what people with histories of incarceration want. And I understand that this came up in conversation at the other session during noon. But what's appropriate to share? What if some behaviors are criminalized that aren't, that are considered criminal when a person's incarcerated, but not when they're home? What do we share? And so again, in each of these endeavors, the critical piece is having people with histories of incarceration, even talking about how you evaluate. TCN has created a white paper of what the evaluation strategy should be. And what we did was we convened people with histories of incarceration to say, it's not just the quality metrics, but what are the process measures? And one of the things that they wanted to say is are co-payments gonna be leveraged in those 90 days? That's something that is those of us that aren't practicing inside or outside, you wouldn't think about. But immediately that was one of the first questions. What percentage of the cash is going to carceral systems versus the community? How can we shift the funds into community organizations? And so having people with a history of incarceration build a new table is critical. And I think that the piece of it is not just because it's nice, not just because CMS says it in its guidance, but it's gonna get us to, I think, more healthy and well communities. And so I think that that's what I wanted to end with, is Medicaid has this potential ability right now, profound ability right now to bring together the right stakeholders. And because Medicaid hasn't ever worked in the carceral system, the key people to bring in are people that have been incarcerated themselves.
And I really appreciate there too this idea that, we are all kind of data hungry. It supports a lot of our work. And in cross-sector collaboration, one of the risks is around kind of what is an ethical and accountable use of data, and who is that data accountable to, who has access to that data. And so I really appreciate you raising that up as sort of something that we should all be thinking about when we're embarking on kind of our ethics and our governance of a cross-sector collaboration. With that, I think I'll turn it over to the audience. I have a bunch more questions, but I know that this is something that kind of folks have been working through today. And I see Vicki over there raised a hand.
Hi, my name is Vicki Poulos. I work at Mass Law Reform. My question is for the two Massachusetts folks on the subject of silos and breaking, siloed stuff. I know Mass Health has said for the last 3+ years it's been talking to its correctional partners about the Medicaid inmate exclusion waiver. To what extent have its own ACOs and the DPH Correctional Services been at the table and been part of those conversations?
Actually, I'm obviously familiar with MIEP, but my work in this field is new. I'm not entirely actually clear to what extent DPH has been involved in those conversations, to be honest.
So the Mass Health process is pretty transparent, and they have a lot of stakeholder engagement. I sit on a delivery system technical assistance committee for my organization that just started this round with the new contract just started. So that hasn't been a topic of conversation there, but I know it was in the past. So I think that Mass Health has done a good job of bringing in ACOs to get feedback, but certainly there's I saw last week that the waiver went through again. I think that we're looking at a budget neutrality question at this point. So lots of opportunity to provide input, but a lot at the end of the day it comes from CMS to Mass Health and then to the ACOs to implement.
But has there been even one meeting where you've been at the table with the correctional partners and Mass Health and you've talked about the inmate exclusion and delivering services to people on reentry, whether managed care in reach inside or any of those conversations?
I have not been part of that. So the question was, have there been meetings with the Department of Corrections and ACOs at the table? I have not been part of that, but that's not to say that it hasn't happened.
And I think that Vicki's highlighting a really important kind of process question, right? So for many states, some of this isn't going to come into play until they're working through their implementation plans, which they submit sort of after an 1115 waiver has been approved. But I think what I hear is this real opportunity and this real need to say from the very, very beginning, hey, let's talk. How are we going to make this work? Start building those relationships that are a crux of collaboration really, really early, and start doing that asset mapping really, really early. So thanks for bringing that up. Any other questions?
Hi, my name is Rachel Gershon. I'm with Justice and Aging. And with an aging adults lens, knowing that the prison population is growing older, in part because of the 1990s crime legislation that made longer sentences happen. Are you seeing any innovations in care coordination at reentry into home and community-based services, like a personal care attendant, other things that will be helpful for our disabled and aging folks coming into the community?
I'll give a very brief answer, which is that I think the system itself is complicated enough that we shouldn't overcomplicate it with some extra add-on thing. And like I said, if somebody comes in with Medicaid, then we have all of these extra supports that we can help get. So I haven't seen that yet, but again, once they get Medicaid, then we can offer everything that we always do, which is comprehensive behavioral health and substance use and complex care and specialty care and all that.
One thing maybe I'll add to that, which is that I haven't seen, interestingly, when patients are incarcerated, the activation of Medicare, which is what I think you're alluding to. And this, to me, seems like, again, given the aging of individuals behind bars, people have worked, they've contributed, and then come home. Very rarely are our Department of Corrections colleagues kind of attuned to trying to get folks onto Medicare prior to release. And I think that there are opportunities to move that forward. I also, this is again clinically, just seen individuals that essentially are requiring nursing home care. And during COVID, certain states, some did it better than others, really decarcerated those that were very chronically ill, should have been released under compassionate release, didn't, but under COVID they did. And there were not nursing home facilities that enabled the safe transition of care for people to return home. And so again, the question is back reflected on us. It's not that our correctional leaders were unwilling to decarcerate or unwilling to release. They in fact were willing to. And our nursing homes, nursing home facilities, home health agencies wouldn't take certain sorts of patients, those with criminal records. And I think that this requires deep reflection.
And I think that what I've heard too is that one of the opportunities of kind of the pre-release period is that we have more time to sort out some of these issues. And hopefully we have the right partners lined up, but we also know that there's long wait lines and that there's not always a supply of providers. And so it gives us more time, an on-ramp to kind of putting those pieces in place.
Can I ask a couple folks or anybody in the panel what they think of another collaborator possibly? I'm a healthcare person for 50 years, including a few med schools, and we were taught basically we could solve any problem imaginable. Not true, of course, but we were taught that. And in Massachusetts, the folks who got the governor to do the ID policy change, which Emily mentions, which I'm a reentry court case manager myself, it's a huge problem still in Massachusetts. But the Greater Boston Interfaith folks worked with the governor, interfaith group, to get her, persuaded her, and she agreed, she's working on it. Mass DOC is working with the RMV in Massachusetts to get an ID for people, knowing how important that is. In Baltimore, BUILD, interfaith organization, is the one that persuaded Ron Peterson, the head of Johns Hopkins, to hire people into real jobs, not just any old jobs at Johns Hopkins. That interfaith organization still is. They run Turnaround Tuesday. I just wonder what people think about that collaborator and whether in San Diego or anywhere else, folks are working with those folks. They seem to have a lot of power, and it's not just by praying. They're good community organizers. That's how they get their work done. They don't pray about it, they do it. I just wonder if you thought about working with any of them, or do you work with any of them?
I'll answer your question in kind of a general way, which is that there's been a lot of discussion of how smaller community-based organizations get involved. This is a great example of it. You know, when things come up that need to get done, our county doesn't have the manpower or the budget, and so they really do convene and they allow community-based organizations to move forward and do that kind of thing. So it is happening, yes. We are working with whoever is willing to do the work on the ground.
We just have a few minutes left, so I'm gonna turn it back to my panelists for one last rapid fire round of questioning and answer. And I just want to hear from each of you what is sort of one place to begin this work in building the right collaborations. And so for anyone out there who is thinking about how to start, or maybe you're thinking about how to expand a thriving collaboration, or you're thinking about, you know, how to revive something that's fledgling. What is one word of wisdom you want to share? Sentence of wisdom, not word.
I can start that there's that expression, don't let perfection be the enemy of the good. I mean, just sort of, just start. I mean, if you wait for the ideal time, the ideal people, hopefully those things will fall into place. I think you just sort of need to get going. Let people know what you have to offer, find out what the gaps are, and try to fill those gaps with other people, other partners, I would say.
I'll just say that, you know, California is a state of 40 million people, and it's the 5th biggest economy in the world. And I just looked up the numbers. The population of the state of Massachusetts is about 7 million. The Medicaid population in California is 15 million people. So we're happy to go first and fail miserably and let everybody learn from all the mistakes that we're making. That's the whole point. This is I think the whole spirit behind these waivers is to allow individual states to do individual experiments and see what's happening. And things are gonna come up that we don't realize, like, oh my gosh, we didn't think about this. Like, something we have not talked about at all is that California expanded Medicaid to undocumented people. At the same time, we're trying to do all this. And everything we've said is for Medicaid eligible people that are in prison. What about those that are not Medicaid eligible? What are you gonna do for them? Nothing right now, right? So you're gonna start iterating these things and find out, oh my gosh, we didn't think about that. It's a huge problem. It's a very complicated car that needs gas and brakes and turn signals and all this kind of stuff. And all the people need to be working together on all this stuff, but we are gonna learn from each other. I was very happy to see the California administrator say, this is 2 years for us to roll this out to prison. We would fail miserably if we put a deadline and said this has to be by December. It's gonna take a lot of time, there's gonna be a lot of failure, and we just need to be open and transparent about that and learn from each other.
I would encourage to make these programs as low barrier to entry as possible. When we attach money and new programming to Medicaid, we add in a lot of health needs-based criteria, which can make it even more complicated. And so to make the programs as broad as possible, so that when we can, working with whatever partners possible, we can engage people as part of the reentry process, all the better. In all of our health-related social needs work that we're doing as an ACO, I never want to find someone and say, oh, so sorry, we can't help you with your food needs, we can't help you with your housing needs because you're not sick enough. And so making these programs as easy to access as possible so that our great community health workers and people can really engage folks the better.
It's like everything good's been said. So I would say I similarly think that, just to get started, to start now, to engage people with histories of incarceration. In California, in Transitions Clinic Network, it was cited in the work that Autumn presented, was at the table but not initially at the table. Formerly incarcerated individuals are at the table now. They were not initially. To include now, and to create a space where honest communications about what is going to be expected of formerly incarcerated individuals as they are at the table, whether or not real power sharing is going to happen or not, I think is of critical importance. But I also think it's also important to not create kind of a stakeholder table of just justice-involved individuals where they are like kind of token at the end. Oftentimes you see that in policy, it's like, yeah, we ran it by them, but they aren't at the table where decisions are made. And so to create, again, a policy-making table that includes justice-involved individuals now, it's not gonna be perfect, ugly things are gonna be said, that's expected. This hasn't been tried before, but over time, if started with intentionality and relationship building, can really, I think, amount to the transformation that we need to see.
And with that, our panel is over, and thank you all so much. I've really appreciated learning from you.